Good morning, ladies and gentlemen. Welcome to the DXS International PLC investor presentation. Throughout this presentation, investors will be in listen-only mode. Questions are encouraged and can be submitted any time via the Q&A tab situated on the right-hand corner of your screen. Simply type in your question and press send. The company may not be in a position to answer every question it receives during the meeting itself. However, the company review all questions submitted today and publish responses where it's appropriate to do so. These will be available via the Investor Meet Company dashboard on the website. I'd also like to remind you this presentation is being recorded. Before we begin, we'd like to submit the following poll. I'd now like to hand you over to David Immelman, CEO, and Stephen Bauer, COO of DXS International PLC. Good morning.
Hi, Paul. Good morning to you.
Good morning, Paul.
The floor is now yours, gentlemen. Thank you.
Great. Well, thanks. Thanks very much. Well, firstly, I'd like to just thank everyone attending this presentation. Thanks for making the time and the effort. We're excited to share our business with you. And of course, for those of you that already know quite a bit about the business, I have included some information here for the benefit of people who may not know as much as you do about the business. So it may seem to be a bit repetitive, but bear with me because I think overall it's going to be exciting and interesting. I'm going to approach this with a very short overview of the actual business. I'm then going to get into telling you what it is we do, more about it, how we do it, and then I'm going to be talking about the new areas into which we're moving and why we are and what opportunities that those are presenting for us as a company and for shareholders. So without any further ado, I'm going to put this video off. It's going to make it easier to present. And yeah, let me start. Thank you. Right. So, as a business, we provide clinical decision support to approximately 20% of GP practices throughout the UK. And I'm going to tell you more about clinical decision support in a few moments. Clinicians use our proprietary clinical decision support solutions, and that's an acronym we'll be using throughout the presentation, CDS, which are deployed at clinical sites such as GP practices. And importantly, these systems are interfaced with the various patient electronic healthcare record systems. Obviously, the reason for that is because we need to be able to be analyzing each patient's data to provide tailored information to the person, the clinician who's in the patient encounter and about to treat that patient. We currently have an annual turnover of 3.4 million. And have ambitious plans on how we're going to grow that revenue going forward. Currently, we have invested over £4 million into the development of what we call our new expert clinical decision support solutions. And that's what I'm going to be talking about later on in the presentation. Clinical decision support, what is it? For clinicians, we provide treatment decisions in the form of guidance, alerts, and reminders in their workflow and during the patient encounter. And as I said earlier, what it boils down to is a busy clinician, and while we all know these people are incredibly bright, they have so much information that they have to deal with so many different patients on a daily basis, that we try to help to distill information for them in a meaningful way. The other side of the coin is communicating with patients. And we do this via SMS messaging or an app, and we send reminders and requests for medicines, measurements, medicine information, blood pressure readings. We provide lifestyle advice. And I think you will have heard, many of you, and I'm sure you'll agree, that it's becoming more and more important for patients to start taking certain levels of responsibility for their care. And so this is a way of setting up these channels of communication with patients. And I think this has become a lot more evident during the past year with many of the consultations being conducted online. One example. What are the benefits of clinical decision support? Well, we as a business, we don't make these incredibly complex clinical decisions about how you should treat a patient. We leave that to the experts. And gold standard treatment advice exists. It's there. And if implemented according to the existing guidelines, the outcome is that this will result in the best possible outcomes for the patients, clinicians, and healthcare payers. And what we mean by that is that if you look at I use 3 organizations at the bottom. The first block is an organization called NICE, UK organization called the National Institute for Health and Care Excellence. This is an organization that is highly regarded, not only in the UK, but around the world. And they will create treatment guidelines and pathways. And if we pick something, for example, like diabetes or COPD or asthma, if you picture a pathway, it's almost, as one of our GPs said, imagine it to be like a GPS and you're driving in your car and you're trying to get to a destination. And you could turn right, turn left, go straight, etc., because these are all points of different decisions that need to be made based on certain information about that particular patient, such as their medicines they're on, their clinical parameters that they present with, their age, their demographics, and so on. You can just picture in your mind how incredibly complicated this becomes. And so these organizations, they've created all this information. It exists. In the US, the organization that handles and is the gold standard for treating heart disease is the American Heart Association, and the same in Europe. But with clinical decision support comes a challenge. You know, this information is complicated. And if we use the NICE guidelines as an example, they are, particularly if you look at guidelines for long-term conditions, and I'm going to talk about that in more detail. Let's take a hypertension guideline. If you look at the guidelines for hypertension and their related comorbidities, you're looking at 300 plus pages of information. It's staggering. If you look at the guidelines for diabetes, 278 pages. Now, again, I said, you've got incredibly dedicated and busy, overloaded clinicians. And so the challenge that we have is to take this gold standard information and to present it in summarized bite-sized chunks in the workflow and during the patient encounter. This challenge is exacerbated at the moment by an increasing shortage of doctors, of GPs. And this is not only in the UK, this is applicable globally. Let's just look at a few facts. In the UK every year, you have about 330 million consultations. It's a staggering number. And 150 million of those consultations, 50%, were for people with long-term conditions, also known as chronic conditions, things like hypertension, asthma, etc. And these are diseases that are difficult and complex to treat. And again, I'm going to go into that in more detail a little later. When you think that the time per consultation in the UK, according to the National Health Service, is about 10 minutes, you start to imagine the quantum of time that is spent on long-term conditions in these consultations. Add to that a current shortage, or estimated shortage, of about 6,000 GPs in the UK. And recent information is that 49, this is a survey that was conducted, 49% of GPs plan to reduce their clinical hours, 11% are planning to retire within 3 years, and 15% are planning a career change. You know, this is serious, it's staggering, and it impacts on a lot of people like you and I who depend and rely on these amazing clinicians to manage our healthcare. So how do we as a business contribute towards solving this problem? I said earlier, step one, if you look at the first box, we take these complicated treatment guidelines. And then we have teams of a combination of clinical people, software development people, and others. And we build this information into our clinical decision support solutions. And these are in 3 basic formats. One is what we call guidelines, more like document formats. The second is more sophisticated templates and tool sets supported that then has data out of which you can extract reporting that is important. And finally, the area which we are incredibly excited about, and we're going to be also talking more about, is into our new expert solutions, which are using smart rules-based algorithmic systems. We take these systems, our clinical decision support solutions, and then we connect these to the patient's electronic health record. And what that enables us to do is to extract the data from the record and to then personalize the treatment advice for each of us. Again, I mentioned earlier that uses data such as your demographic data, your clinical data, your medication data, and other information that is available. And using that information, it now instantly presents these busy clinicians with summarized, concise advice in the workflow and during the patient encounter. And I said previously, patients too are receiving their personalized advice in their app or via their text messaging in an effort to get better patient engagement. I want us to just have a look at how our clinical decision support has evolved. And we really here are pursuing excellence. It's something we're proud of. We started out, if you look at the bottom of this curve, with what we called passive technology. And that was really more about presenting guidelines and documents in the workflow of the clinician. From there, we've moved to more interactive workflow tools and templates. And this is where we found ourselves in 2020, and currently we continue with that. And we have teams and with clinicians, developers, and so on, who build more sophisticated templates and tool sets that enable a clinician or a nurse to work through a particular patient's problem in a very systematic kind of way. But it is still time consuming. It does require that time which we've said is such a problem and an increasing problem, or the lack of time. Where we are in 2021, I said earlier, we've invested over £4 million into our expert rules-based clinical algorithms. What is the difference? The difference is that we can take that 300+ page hypertension review, and we've built our own intellectual property with these amazing teams we have. As I say, they consist of doctors, pharmacists, mathematicians, software developers, and many others. And they extract all of that data into our IP, into the system, into this expert rules-based system that we built. And so that when that system accesses a patient's record, it instantly auto-analyzes all of that patient's data against our rules-based engine. And it pops out 3 or 4 simple recommendations on what should be done about that patient. And if I use hypertension as an example, it will, the suggestions or the recommendations, which by the way are then in line with the gold standard that has been presented by those experts. It might say, we recommend that you stop this drug and this is the reason why. You add this drug and this is the reason why. You increase the dosage on this drug and this is the reason why. And if you do that, that patient will not only be now treated in what they call compliance with the gold standard recommendations, but we know that once patients are being treated in compliance, then a lot of the other outcomes will improve. Their blood pressure should improve. So if their blood pressure wasn't controlled at the time, if they treated in compliance, controlled blood pressure should become an automatic result of compliance. And this is what we are so unbelievably excited about. And we're going to talk about that in more detail. And then where we're heading. We've all heard about artificial intelligence. It's bandied about daily at the moment, and case-based reasoning. I have to say that while it is unbelievably exciting, and there's a huge amount of effort and work that's been done in this area, at the moment, as far as healthcare goes, AI is still rife with problems. It's not a panacea yet, but unquestionably, it is the direction of travel. And we are making sure that we are going to be collaborating with the experts in this regard so that we can marry up what we do, what they have, and ultimately come up with even more incredible solutions and outcomes which will result in better management of healthcare. If we have a look at our current solution suite, we've adopted a modular approach. And I've talked about the where we are, where we started and where we are. And those 2 products are DXS Point of Care, which is our live solution and current revenue earner. Complete Care is the more clinical tools and template-based solution, which helps to navigate complex consultations. We have bundled that together now with Point of Care. And so it takes Point of Care to another level, and we're in the process of marketing and selling that solution in the UK. The 2 systems at the bottom, Expert Care and My Vital Care, those are the 2 solutions that form part of our new expert algorithm-based type solutions. And for every pathway or long-term condition that is recommended by the experts, you can kind of divide that guidance into 2 parts. The one part is with the clinician-facing part, which largely deals with medicines and that sort of thing. And the other part is the part that deals with the patient, and that's My Vital Care. So the expert care part is currently in the pilot phase, and we started that last year. I will not pretend that during this time of COVID, it has been very difficult, understandably with the pressures clinicians have been under. And it's been, but trying to get the traction and get it going has been pretty tough. But we have had good pilots. We've had feedback, we have enthusiasm, and I'll give you some more info on our pilot shortly. The My Vital Care solution, which we had informed our investors we would be piloting last year, we've pushed that out, and we hope to be beginning those pilots in May this year or thereabouts. We may find it could be later. We don't know how soon things will begin to normalize. Now, I've talked about the general management of providing clinical decision support for diseases generally. But with our new intellectual property algorithmic solutions that we've developed, we have made a conscious policy decision to focus and become experts at the management of long-term conditions. And here I'm just trying to show you, these are 10 common chronic conditions, and I think some of you will be shocked at the percentage of us that have got some of these conditions. Hypertension, 58% of us over 65 have got diagnosed hypertension, and that puts aside the millions that are wandering around undiagnosed. High cholesterol, 47%. Arthritis, 31%. And you can look through this. It's just diabetes, 27%. It's just amazing. And when we consider these long-term conditions, that 30% of, I want to say, actually, the thing with rising, with long-term conditions, it's a rising threat. That's what the World Health Organization regards this as. Because it's not getting better, because it's all sorts of problems, you know, lifestyle, obesity, and all sorts of things contributing towards the increasing numbers of people with long-term conditions. And when you think that 30% of the global population have long-term conditions, just do the arithmetic. And here comes the really scary part. 70% of those people, of those 30%, 70% of the healthcare spend is used by the 30% of people with long-term conditions. So let's just break that down into money. The healthcare budget annually in the UK is 120 billion pounds plus. So 70% of that, which is almost 80 billion pounds, is being used by 30% of the population who have long-term conditions. And that's the fact. This is made worse by the fact that there's an increasing aging population, and 20% of the UK population will be 65 by 2030 or over. Long-term conditions are the biggest financial challenge for healthcare funders, such as the National Health Service. They acknowledge that if the guidance is there, if we can improve the way we treat them in adherence with our guidelines in this best evidence medicine, we will cut costs by keeping people out of hospital by averting events such as heart attacks and strokes and things. All of this problem is made even worse and more complicated when you think that people with a long-term condition have more than one. 60% of people with a long-term condition have one or more long-term conditions. So if a person had hypothetically hypertension, there's a good chance they might have diabetes as well, and so on. The World Health Organization estimates that by 2030, there will be a 10 million global shortage of doctors and nurses. And I said earlier that there's a 6,000 shortage in the UK of GPs only. So we, in our roadmap to deal with long-term conditions, we picked one to start with, and we decided on hypertension. And this wasn't left to guys like me who are non-clinical. This was given to clinical experts to make, and loads of research to make these decisions. Hypertension, 15% of the global population, not just adult population, global population, are diagnosed with hypertension, which is 10 million throughout the UK. Hypertension is the major cause of heart attacks and strokes and currently costs the National Health Service £2 billion per annum. The consultations that hypertension requires, just hypertension, is 4 million GP man hours per annum in the UK, which is the equivalent of 2,700 full-time GPs. And the reason is that, yes, there are competent prescribing nurses and competent prescribing pharmacists out there who can manage medicine reviews, complex medicine reviews with hypertensive patients. But at the moment, they are not in the majority, they are in the minority. And therefore, the complex hypertension reviews require GP input. And it's using up huge amounts of time because it's so complicated to treat. Of course, this provides an opportunity to us as a business. If we look at the hypertension opportunity, if we had a 30% market penetration of our new expert care hypertension solution that we have been developing for a number of years and are now piloting, and to give you a sense of what that means, throughout the UK, England, Ireland, Scotland, and Wales, there's about 9,000 practices. These are reducing, amalgamating, and so on. So if we had approximately 3,000 of those practices, which we believe we can access, not instantly, but over a period, the implications is that that could potentially avert 5,000 strokes and 3,000 heart attacks per annum. It could save 1 million GP man hours per annum. That in turn, of course, significantly can improve a practice's profitability. And let us not forget that practices ultimately are businesses. They generally are owned by a couple of partners or maybe by a company in some instances, and they have to make a profit. They have a contract with the NHS, but they do need to be profitable. And so anything that they can do that helps with their profitability is important to them as a business. And last but not least, by managing hypertension in line with best evidence medicine, ultimately can result in savings, according to the NHS, of at least £30 million per annum on a 30% market penetration of our system. Our system, our hypertension pilot system, it's checking the right boxes. This is the feedback that we're getting from the pilots that we're running at the moment and have been last year. When we extract a patient's record or a number of patients' records, and across these pilots, what we're finding is that only 50% of those hypertensive patients, are compliant with the current treatment guidelines. We would love it to be 100% because you're going to get the best outcomes. Remember, we're going to reduce strokes and so on and so on. But the fact remains is that only 50% are currently compliant with the best evidence treatment guidelines. What's really exciting is that during these pilots, after the use of expert care for the first time, compliance went up from 50% to 74%, a 48% improvement in compliance after using our expert care solution once. Because to remind you, the expert care solution is this clever algorithmic rules-based engine that sucks in hypertensive patients' data, analyzes it, processes it through a very complicated pathway, and comes up with a few recommendations that says, if you do this, this patient will become compliant. The other information that has emerged from these pilots, and this is something that we are emphasizing and working hard towards, because this product has been designed to be able to empower nurses and pharmacists, non-GPs, to conduct hypertension reviews with minimal GP input. And that's how we can save significant GP time. And that is in line with the National Health Services plan at the moment. They are encouraging these primary care organizations, primary care networks, to hire prescribing pharmacists, to conduct medicine reviews, and even are sponsoring part of their salaries, because they recognize that they need to delegate part of the work to these pharmacists and nurses to free up these qualified doctors to be able to focus on what's really important. Not that this isn't important, but for them to be able to do that, them being the nurses and the pharmacists, they've got to have the right tools. And that's what we're providing. Our pilots have also shown that on the feedback, that more than 90% of the clinicians who have used this expert care product are enthusiastic about it. The feedback has been really good, beyond what we expected. If you look at our expert care hypertension solution and the benefits that it can provide, is we've worked out that an average 9,000 patient GP practice can be saving about 328 GP man hours per annum. And after removing some costs relating to recruiting a pharmacist, that represents a 25,000 pound annual saving on the bottom line of that practice, which is significant when you consider that the investment that the practice would need to make for our solution, they would be getting a 10 times return on investment here. The saving to the National Health Service for that average size practice would be around 14,000 pounds, and that's by reducing heart attacks and strokes. And of course, let us not forget the outcome, and we will be having healthier, happier patients, which of course is the end goal of all of this. Now, we are aggressively planning to grow our business. And yes, we had hoped this would start last year, but we had some unexpected interruption. So what we're doing is we will continue selling our existing DXS point of care and complete care solutions, which I went through earlier. And following these successful pilots that I've been talking about, we will launch our new clinician and patient-facing hypertension expert solutions. And we hope that those launches are going to be happening, I like to think maybe May, June, July, somewhere around there, if all things being equal and vaccinations go as well as they are, etc. And then let us not forget that in the future, our engine, our IP that we have developed, although we have picked hypertension as the first point of entry, we have a roadmap to add new long-term conditions into that engine. And we have clinicians asking us about that, and what are we going to do next? And then we ask them, well, what would you like next? And, you get varying answers. And some of them are such as diabetes and others to this engine. So that will be exciting for us as a business, because it will provide the ability to then upsell on top of our hypertension solution for additional products. And I have a vision, and I can see eventually how these highly competent GPs in a practice will have been able to delegate a lot of this type of work, this review work, to competent pharmacists and competent nurses that are adequately trained. Then I want to talk about the international market. I said earlier that this hypertension problem is a global problem. It's not limited to the UK by any means. And last year, we being my colleagues and myself, came across a tender that was put out by a consortium between Turkey, Croatia, Italy, and Sweden. And these 4 countries that have a population of 90-odd million people and 30 million hypertensive patients, according to them, they formed this initiative and they conducted huge amounts of research into hypertension, and they decided that they needed to tackle hypertension. And of course, when we read this, considering that we've been beating this drum for years and years and years, and when we started reading through this tender, we thought, my goodness me, this is as if someone has read our minds and knows what we're planning, and they want to do exactly the same. And we decided to have a go at tendering for this tender. Now, the tender is divided into 3 phases. Phase 1, which is 3 months, was to be able to produce your architectural drawing, for the want of a better word, to them to say, this is how we're going to build this solution for you. And for that, if you won phase 1, you paid for phase 1, and then if you succeed, you move through to phase 2. So there were 7 people that were selected for phase 1, 7 organizations. And we were one of them. We're pretty excited and proud to say that we're a small business up against some heavy hitters there, and excuse me, yeah, we're excited that we were granted this phase 1 award. So we've got our work cut out for us, as you can imagine. Started on the 1st of March this week, and it ends at the end of May. And we're going to have to work flat out to hopefully produce an amazing tender that will then see us moving through to phase 2. Of the 7, 3 or 4 will move through to phase 2, and they will then have 8 months in which they need to develop the actual products that they have presented in phase 1, and for which each of us that get through will be paid. And then at the end of phase 2, they will whittle that down to 2 companies who will take what they've built and they will pilot it over a 12-month period, and for which they will be paid. And at the end of that 12-month period, they will be expected to then take what they've built and to try to commercialize it. So if we can get through with this, it'll be an amazing funded way of getting a product built for a particular territory, because even though we've already got a lot of the technology, there will be a lot of localization and languages and stuff like that. But it would be a fantastic opportunity for us to end up after 24 months with a sound solution that could be applied throughout the European Union and give us an opportunity to go in to try and market it and sell it commercially. I mentioned that there are 90 million hypertensives in those people in those countries, but throughout the whole of the EU, as a matter of interest, there are 90 million people with hypertension. And so that shows us the sort of opportunity if we can get through. But you know, even if we don't get through to phase 2 or phase 3, We already will have the architectural drawing, we'll have much of the solutions already built and functioning. And as the EU was always one of our intentions to target, it would be a great springboard for us into that market. So we're very excited about that. The USA, I know it's a big market, and I know many companies who have come away with their tail between their legs and so on and so forth. And so we have a very, I'm going to say, careful approach here. And how we're doing that is, we started out by doing a huge amount of research into hypertension in the US. Again, it is a huge problem, accepted and identified by all the powers that be there. We have demonstrated our UK product to US cardiologists and family physicians, and there's a clear endorsement for the need for hypertension, for an expert solution such as ours. And so we are at the moment in the process of localizing our UK version into a US version. What that actually means is, you know, here we have UK drugs, there we have US drugs. Here we have UK clinical codes. And so we've got people matching these up at the moment. Here we have the nice pathway for hypertension. There we have a different pathway. And so we'll have a clinician who will take the data and put it into our IP, because it's designed to be able to do this. And once that's completed, then we will get a couple of those pilots going. And we hope to have some pilots going towards the end of this calendar year. And following some successful pilots, we hope that we could start to try to identify some value-added resellers. We call them VARs. And these are companies that were already operating in the markets where our products can be used. And so the idea is that we will share revenue with them. And they will, if we're selling at £1, they might get 70% or 60% of the pound, and we may take 30 or 40% of the pound, and each of us will have our responsibilities. And that way we will hopefully avoid having to try to go and replicate what we do here and set up offices and people and try to leverage off organizations that already are in those market sectors. The UK has 108 million hypertensive patients. And we reckon if over 3, 4, 5 years we can target maybe 10% of them, you can start to imagine the kinds of revenue streams that we could potentially earn through those countries. We have spent a lot of time and effort and money building something amazing. If we do not be brave, sensibly brave, and get out there and make the most, aggressively market these solutions. And of course we may, and I did say this a year ago, that we would require to at some stage to source additional funding for that. But we need to get out there smartly and capitalize on what we believe the edge is that we have at the moment with what we've developed. And this is what's going to give us the exciting revenue curve. And it's going to help us finally to grow this business. And we've been planning this for a long time. Just a little bit about our company and some of our endorsements that we're proud of. We are an NHS accredited company in the UK. And in particular for DXS point of care, it means that it does receive central funding for prospective clients to buy. Of course, provided that they have budget available and they haven't used up all their budgets on other things. Our expert care hypertension solution is regarded as a medical device. And we spent the last probably 18 months working on accreditation, which we're happy to say we now have. So we are it is a CE accredited solution. We also, as a company, are ISO accredited, ensuring our investors that the company is run within the ISO rules and regulations, and therefore that we do implement proper governance and all sorts of things that is required from us as a business. And down at the bottom there, I talk about our partnerships. Now, to operate in this environment and to operate in the environment in which we do operate, I said earlier that you have to have access to patient records. And so currently we have individual partnership agreements with EMIS, System 1 and Vision, which give us secure access to 95% of the UK patient records. EMIS is the largest of the clinical system providers. They have about 55% of the market. System 1 probably has about 35% of the market. Vision has probably got 6 or 7%, and then the rest goes to a much smaller company. And the London Procurement Partnership is an organization that enabled us via a tender process to become an accredited supplier to that procurement partnership. They represent members, and currently they have 30 members that are a combination of NHS trusts, hospital trusts, and clinical commissioning groups, and those CCGs are in primary care, and each of them represent 40 or 50 GP practices. And that's another method through which they will put out tenders by their members, but then they circumvented and they mini tenders that we can then respond to as an accredited supplier to them. Of course, we never lose sight of our customers, because quite frankly, if the customers do not love and like what we do, we're dead in the water. We can be talking to all the other organizations, but if the doctors, the nurses, the pharmacists, admin people do not love what we have, we are dead. And we make a concerted effort to try to respond and deliver the best possible service and, of course, solutions. Have we made mistakes in the past? Yes, we have. And we try to learn from those mistakes and move ahead and prove and show to our customers that we are the right people they should be working with, because we are willing to respond. Just a short, quick snapshot of last year's turnover. For the year ended April 2020, we turned over £3.2 million. We are a small business, but we're around and we're still there, and we now are going places with what we have and what we've developed. Our turnover for the half year in October 2020 was £1.7 million. And we showed a profit for the period of 2020 of £28,000, and for the half year of £24,000. I just pulled out of the balance sheet what I thought might be some salient points. By October last year, our investment, I've said, into new IP was over £4 million. We had cash in the bank of 1.2, some revenue that we receive in advance, and those were our shareholder funds. So to summarize the opportunities of which I've been talking about for the last half an hour is we certainly plan to grow the UK market, and that is through a combination of existing systems. And on top of that, our new expert solutions that we've been working on, because we truly believe that is what's going to take us into the next serious level of revenue in the UK. And of course, not needless to say that one of the ways we're going to do that is by leveraging off our 2,000 existing GP practice markets. But we have already last year started a marketing and exercise where we are targeting key people at a number of different levels, and this goes from ICSs down to CCGs, down to their primary care networks, down to practices, and to the people within the practices, doctors, partners, clinical leads, people with a special interest in hypertension, practice managers, pharmacists, and so on. And it's all about communicating with these individuals and trying to share with them using the power of LinkedIn and email and whatever other medium we have at our disposal, working with the organizations to whom they may subscribe, such as the Practice Manager Association, the Pharmacy Association, and so on and so on. So we're trying to come in at a multi-pronged approach. We're going to do our damnedest to try and win phases 2 and 3 of this tender. We know what we're up against. We're not complacent, but we're going to give it our absolute best shot. And I hope when I speak to you again, I'll be able to be smiling and saying, well, we got through to phase 2. So, but it's not a given. We know what we're up against. We're working to establish a US pilot. It's work in progress at the moment. Localize the product, get the pilot, and hopefully it's going to be a successful pilot, and then start and like I said, we will need to be raising some funds. And then, of course, I mentioned we will add new long-term conditions to our expert engines, which will then start to give us the upsell opportunity. And of course, let's not forget the huge benefit to the people that have to manage these conditions. And then our longer term vision is, I said it earlier, is we'll continue working with experts in the field of artificial intelligence and also DNA and personalized health. And, this is nothing new. And this sometimes, I think for some people, this seems like a million miles away. It's not, it's happening. The NHS has an initiative that's been going on for a long time. And if you can picture how this can work, here we have a hypertensive patient, and we can now follow that hypertension patient's journey, juxtapose their demographics, they were male or female, their age, their conditions, and they were being treated according to certain medicines, and look at the outcomes that happened. And now imagine on top of that, layering that person's DNA, and eventually an amazing picture begins to emerge of the effectiveness of treatment against the DNA. And I think you can all see just how powerful that could be going forward in the future. And that brings me to the end of what I hoped was an informative presentation, and I hope you can see that we have a plan and we're excited about where we're going. So thank you again for your attendance, for your interest, and we hope in maybe 6 months' time we will provide you with another presentation, something similar, and at least been able to tell you how we have progressed against some of the plans we've presented here today. Thanks very much.
David, thank you very much for the presentation. Ladies and gentlemen, please do continue to submit your questions using the Q&A tab situated on the top right-hand corner of your screen. Which is while the company take a few moments to review those investor questions submitted already, I'd like to remind you that a recording of this presentation, along with a copy of the slides and the published Q&A, can be accessed via your investor dashboard on the Investor Meet Company platform. I'd also like to remind you that your feedback is important to the company, and immediately after the presentation has ended, you will be redirected for the opportunity to provide your feedback in order that the company can better understand your views and expectations. David, Stephen, just kind of conscious of time, but we've had a number of pre-submitted questions from investors, and perhaps I could just start the Q&A session off with these, if I may. The first one, I think, if I could address that to you, Stephen, if that's okay. Who would you say are your main competitors in your space, and what sets you apart from them?
Thank you, Paul, and thanks for this question. Well, in the healthcare sector where we operate, and as you can see from the presentation that David has taken you through, there are significant needs in this market and challenges to be overcome, and that, of course, presents great opportunity. And that stimulates competition, of course. And whilst generally we view competition as good and healthy, it means that we need to be on our toes. And one thing in our favor is that there are significant barriers to entry to these markets, and that places us very well for the future. And with those barriers, it's only really the companies that are very focused and committed to excellent service that can stay that distance. So, but it is a challenging market, of course. And one of our very strong advantages is that we are integrated with all the major medical record providers in the UK, like EMIS and System 1, as David mentioned. And this means that we're able to provide solutions that go across those disparate systems. And that's really important because it levels the playing field, it standardizes the care that gets offered. And we also see that clinicians are wanting to practice flexibly, work in a way that supports their kind of lifestyle and so on. And that was happening before the pandemic, and we've seen that really accelerate through the pandemic. So, with our platforms that go across the disparate EMR providers, it allows those clinicians to move to different practices, to operate in different care settings, and still have the familiarity of our products, which is a really good advantage. And with our expert care solution, we also see that we've got currently a first mover advantage there. And as David said, we've got to be aggressive with our sales and marketing approach, both in the UK and internationally, to really capitalize on that first mover position. So we're very conscious of that. So I'll hand back to you, Paul.
That's fantastic. Thank you very much. David, perhaps I could pass the next one on to you. I think you have touched on this during the presentation, but how large is the market opportunity for DXS, and how do you look to scale the business?
Yeah. Well, I mean, as I said, and I'm going to be talking here about our hypertension expert solution, because I emphasize that is where I believe our greatest growth opportunity lies. I mentioned to you that when you consider, and let's take the countries that we are now focusing on. I said to you that the EU have 90 million hypertensive patients. The US has over 100 million hypertensive patients. In the UK at the moment, we have 10 million hypertensive patients, just to put it into some sort of context. Now, if you look at our business model, unless for any reason the model has to change in a particular country for whatever reason, the current models that have been presented are presented on a per patient, registered patient basis. And what I mean by that is that if a practice has got 10,000 registered patients, we know that 15% generally across the board will be diagnosed with hypertension. So 1,500 of those people will have hypertension. So if you take the collective numbers for the UK, for the US, for the EU, we're talking about a total of about 200 million people. That's just people with hypertension. That's not representing their population as a whole, but that will represent about 15% of their overall population. We will be charging a fee, a recurring annual fee per registered patient. So if, for example, we could access 10%, and I'm not saying this is the number, it'll vary on territory by territory, but for the sake of simplicity, if we could access the market that represents 10% of the 200 million hypertensive patients, that means we would have about 20 million hypertensive patients. And that in turn would probably be representing, if you want to work it back to the population size, it's quite significant. If you say 15% is the 20 million, then you're looking at about 100+ million population to get to that number. And so we generally charge on a fee per registered patient. So you can do the numbers, and you can just picture that if you had 20 million or 30 million or more patients for which you were being paid a fee per annum, and then adding to that, you had people with diabetes being added on and COPD being added on. It's a SaaS model, isn't it? Software as a service model. And so you can see how that market can considerably grow. It is huge, and it is up to us to see how aggressively we can get in there. And there's a model here. Have a good product, prove it, have it endorsed through the right organizations, make sure it produces unbelievably incredible reporting, because reporting is crucial, and it does. Showing all the returns on investments for people that are paying the costs. If you have those key ingredients taken care of, we can go into these markets, and that will determine how much of those markets we can access. But you can see, even with a 10% access of these markets, it becomes an amazingly viable business. And one of the great things about this model, by the way, is we do not have, it is not heavy on admin costs that are required. It does not need huge infrastructure. It's something that can be managed remotely, hosted remotely. It's web-based. It's got all the right, it ticks all the right boxes for good margins, for scalability, and so on and so on. So yes, I can just say to you, of course, like I did earlier, if we access 30% of the UK market, then that will mean this and that. But you need to see the bigger picture here. And I think that's how the market was, the question was asked.
That's fantastic, David. Thank you. David, Stephen, I'm kind of conscious of time. We have just run over the hour. And having said that, we have got a further number of questions that have been submitted from investors. I don't know, perhaps if you could just have a little scan through the questions that have come through during the event, and if there are a couple you could perhaps pick out before we direct investors to give you some feedback, perhaps.
Well, there's a question here. It says, what is the budget for the initial US pilot? If you go onto the HS Monitor website, all that information is readily available for you there, and you can, rather than me take up a lot of time now, it's very, very clearly shown, and I would suggest you go to that website. Did lockdowns in South Africa impact slow development programming? Well, no. Fortunately, we were able to move all our staff to work from home. And for those of you who don't know, we have a back-end operation in Cape Town. And like we did in the UK, every single one of our staff were moved to work from home and were able to do so effectively. The other companies participate in, and this is another question, who are the other 6 companies to phase 2 of EU trial? They're on the website. If you go and have a look, they're clearly set out there. How is our software deployed? Is it cloud-based? This especially, all our new stuff is cloud-based, and even our existing stuff is in the process of moving heavily away from practice-based, which it used to be, to cloud-based solutions. What is the budget for the initial US pilot? Well, maybe you'd like to talk to us and we can discuss that. I think we've run out of time, though, Paul, so
yes, I'm conscious of everybody's time.
Yes,
what I will say, obviously, to all the attendees today is that the company will review all questions submitted today, and we'll publish those responses where appropriate to do so. And we'll also publish the link to the website of HS Monitor, so you can have all that information, as David's alluded to. David, Stephen, look, thank you very much for addressing those questions. David, perhaps before I just redirect investors to give you some feedback, just a final couple of closing words would be fantastic, please.
Yes, I think I'll even put on my my video. Yeah, I really just want to say thank you. We really appreciate your participation, and I hope, and I actually would appreciate if you guys gave us some feedback on this presentation and whether you found it useful and helpful. Whether you do that by sending us an email or through this website. Paul, how can that be done?
Literally, as soon as you finish wrapping up, all the investors would be redirected to give feedback, so you'll get it straight through the platform. Yes,
yes. And any improvements that you think we can make, and anything you think we could do to make a session like this much more meaningful for yourselves, please let us know. And as you know, if any of you feel the need to have a one-on-one conversation, myself or Stephen, we are available. We make ourselves available, and that can be arranged. So once again, thanks for everything. Thanks, Stephen. Thanks, Paul. Everyone else concerned, and I look forward to the next presentation and to the traction that we're going to get.
That's fantastic. David, Stephen, thank you very much for updating investors today. Stephen's asked he'd love your feedback. Could I ask investors not to close the session, as you will be automatically redirected to give your feedback. If you've accessed the meeting via our website, the feedback page will appear in front of you. If you've accessed the meeting via the link in the email, just simply have to log in. It takes a couple of seconds to give your feedback and be greatly appreciated. On behalf of DXS International, we'd like to thank you for attending today's presentation.